Welcome, everyone. I'm Jerry Jarvik from the University of Washington, and today is our inaugural AUR Grand Rounds. So I want to thank all the participants and all of the attendees for trying out this, what's a new venture for the AUR, or maybe adventure for the AUR. And we're hoping to use this first year as a pilot to see what works and what doesn't work as far as the format goes for the Grand Rounds. We established this new lecture series in order to showcase our talented junior faculty who are part of the AUR, as well as to provide an activity that's available and of interest to the entire AUR membership. The idea was that we would pair a junior faculty member with a senior mentor. Each of the AUR affinity groups will take turns hosting the Grand Rounds, offering up a variety of topics that are meant to be of interest to the membership as a whole. And now, except for today, the Grand Round series will take place on the second Wednesday of every other month, more or less, beginning at 5 p.m. Eastern Time, 2 p.m. Pacific Time. Today's talk is sponsored by the Radiology Alliance for Health Services Research, or RASHR, and the speaker for our inaugural webinar is Dr. Patricia Balthazar of Emory University School of Medicine. She'll be presenting an overview of health services research opportunities along the imaging chain. Dr. Balthazar will be joined by Gelareh Sadigh of the University of California, Irvine School of Medicine. Dr. Balthazar is an abdominal radiologist and informaticist at Emory. She completed her diagnostic radiology residency at Emory in 2020, which was followed by an abdominal imaging fellowship at MGH. She has research focuses on health services research. She's an assistant editor for radiographics and has a special interest in diversity, equity, and inclusion. She's received several awards and multiple grants, including the RSNA Research and Education Foundation Resident Fellow Research Grant and the prestigious AUR GE Radiology Research Academic Fellowship, or Giraffe Award. Dr. Sadigh completed her diagnostic residency and neuro fellowship also at Emory. She's an established health services researcher with multiple grants, including R01 funding from NIH. She has a particular interest in the impact of healthcare costs on patients, and importantly, she too is a past recipient of the Giraffe Award. She is currently Associate Professor in Residence of Radiological Sciences at UC Irvine, as well as Director of Radiology Health Services and Comparative Outcome Research. So thank you very much for joining us, and I will turn the microphone over to Dr. Balthazar. Patty.
Thank you very much, Jerry, for the kind introduction. So without further ado, I'm going to start our Grand Rounds today on the topic of health services research opportunities along the imaging chain. These are my disclosures. And the topics that I'll be covering today, for those of you who are not as familiar with health services research, I will be giving a definition, how to get started with health services research, and I'll give specific examples of health services research along the entire imaging chain. So starting with the definition, this is the AHRQ official definition of health services research. And if you read through, it can still be very broad and perhaps a little bit vague if you're not very familiar with the topic. But the way that I understand it, it is a multidisciplinary field of research involving social, financial aspects, organizational aspects, and processes, involving also IT and technology and behaviors, that will look into healthcare access, so disparities, social determinants of health, healthcare quality and cost, and also patient outcomes. So how to get started? I know that at AUR, we also have a lot of trainees, and I want to focus a little bit on how to start with research in general, and specifically with this type of research. So if you are new to an institution, one way to get started is to find someone within your same institution. And you can do that first by trying some PubMed search. I've done that as a first-year resident at Emory. I did Emory Radiology on PubMed and look at all the papers and try to find the ones that, the topics that were interesting to me and who were the authors of those publications. And then I'll reach out to them by email, set up meetings, and find mentors that way. If you don't have people on your own institution, you can also take advantage of opportunities from society meetings. A lot of these society meetings, like AUR, will have speed mentoring events where you can meet people from other institutions and mentors from other institutions. And that is a great way to get connected, because with health services research, you can do it from anywhere. A lot of these databases, they are not institutional databases, they are national databases, and you don't have to be physically on the same place to get this type of research done. And how to get started with the research idea. So one way is to look at the literature, and in every article, there will be a limitation section or next steps that are needed. And those are opportunities for future research. So pay attention to those. Also, be tuned to institutional problems. What are your colleagues talking about? What are they complaining about? What are the problems on your institution, but on a national level as well? And the best way to do research is to actually look at things that are bothering yourself. So what is bothering you? Your personal pain points. You're going to be very motivated to get data and do research on things that you find problematic in your day-to-day. So just be attentive and look for those things in your day-to-day radiology work. This is the imaging chain that we will be covering today. The top left part, the patient and provider decision-making process, will be covered later by Dr. Sadigh, but I'll be covering most of the other things, with except for that and financial toxicity. So starting with the time when the referring provider will place an imaging order in the computerized physician order entry system. A lot of these CPOE systems will have clinical decision support. And one example of research is this paper that we published looking at the appropriateness use criteria factors that were associated with modifying imaging orders. And what was interesting is that we found that inappropriate orders were very rarely changed, very infrequently changed. And when they were changed, it was usually because an alternative recommendation was provided, an alternative imaging order or something else. And only when the appropriateness use criteria was also consistent with the local best practices. Once the order is placed into the system, it goes into our electronic medical record. And this can be a two-way street. And in this step, we can leverage the EMR to help the referring providers remember to order certain scans. So in this paper, the investigators did an intervention to remind providers to an automated reminder, an automated ordering system that will improve the adherence to AAA screening with ultrasound. So once they got that reminder, they would approve the order, and they did a pre and post evaluation and found that improved adherence to guidelines. Once the order is in place, it goes to scheduling. And what we can look at here as an example is what are the studies that are falling through the cracks? What are the studies that remain unscheduled? And this is not only a quality type of paper, but also a safety type of paper as an outcome, and is also one example of health services research. On the topic of scheduling, we can look at the interaction of patients with the scheduling system. And in certain institutions, patients are able to self-schedule their screening mammographies. And we did one study looking at who is actually taking advantage of this type of system. And we found a lot of disparities, and this paper highlighted the digital divide. Once the study is scheduled, it goes to the protocoling list. And what we can do there for the radiologist is to actually look at variability. Is there standardization of the protocols? And that is also another example of quality improvement health services research. By the time the exams are ready to be performed, we can look into rates of no-show. And this is very important to look at scanner efficiency and healthcare delivery efficiency. If we can predict those patients and those no-shows, we can definitely improve the way that we schedule, and our system will be much better. For the exam itself, so we can perform some safety analysis. This is one example looking at 11 years of data to determine if the risk of NSF was high or low after the use of a gadolinium-based contrast. After the exam gets acquired, we have data on the radiation dose. And again, similar to the protocol, we can look at variability across different sites on the same institution. We should not have all these outliers. They should be more or less the same. And this consistency is important because patients going, let's say, into this Emory site versus the other Emory site, they should expect and they deserve to have the same type of treatment. So we can look at that kind of big data analysis inside our institution. This can also be done on a national level. So us as the radiologists will interpret the report. A lot of us are now using structured templates. And one thing that we can look at is the quality of our reports, and having structured templates helps a lot of research because we can parse out some data from those templates. And in this example, we're looking at the quality of the report itself. And we compare the quality of those radiology exams interpreted using the structured template for rectal MRI, for rectal cancer MR, versus the ones who did not use the template. And we found that the ones that used the template had better quality than the ones that did not. And for the trainees on the audience, you can now talk to your faculty and say that you improve their radiology abilities. And this is one paper that proves that. We looked into the rate of addenda on radiology reports with and without trainees. And we showed that the radiology reports interpreted with the trainee were much less likely to have addendum. Once the report gets out, it will get out to various different areas. So the report and the related data will go into first one of these places. It's the registries, the national registries and the national databases. And this is a very important piece for health services research specifically, because this data can be used to look at national trends and disparities and workforce issues. This is one example where we looked at the trends and disparities for CT abdomen pelvis for patients presenting to the ER with suspected renal stones. And we found that there were definitely disparities and that CT utilization doubled from 2006 to 2015. Another example, now using a Medicare database, where we investigate the practice patterns of interventional radiologists and show that a lot of these IRs, when they go to practice, they still perform a hybrid of IR and DR services. So the second place that the radiology report will go is to billing. And a question that we can ask is, are we getting compensated for the work that we do? So if we compare what type of study on a database that is getting done and what type of financial compensation is coming back from billing, that can lead also to a research analysis. And do we need to do structural reporting template adjustment so we can capture all the pieces of information so we get compensated for the work that we do? Next, let's talk about the report going back to the referring provider. So it gets published to the EMR, and it also gets back to the hands of the ordering provider. What are they doing with that information? Is it changing management? This is a study where we looked at the utilization of chest radiographs as a routine chest radiographs after a thoracentesis. And we found that only 0.6% of all of these procedures require a chest tube decompression. And that suggests that these routine chest radiographs might not be needed for all patients. Another important aspect is the incidental finding follow-up. Are the ordering providers actually completing those follow-ups? And if not, what are the factors that are associated with that? And in this study, it was found that patients who got the pulmonary nodule incidentally found on the ED setting were much less likely to follow up. And last but not least, since the 21st Century Cures Act, the radiology reports are now accessible to the patients on the online patient portals. And here's one interesting piece of new information, new area of research that I'm very interested in. One question that we can investigate is whether the patients are understanding the reports that they're getting. In this paper, what was proposed was these two very simple layman's types of messages that patients will receive in addition to their report. In message one, it would be basically a normal study, nothing concerning. And in message two, there might be something concerning. It's not completely normal, so they could understand. And that the level of anxiety with message number one based on survey results decreased significantly. And the sense of urgency with message number two also increased. This was an interesting study. We can also look into patient satisfaction on this step of the imaging chain. So this was our overview. And just to summarize what we talked about today, health services research will look into patient outcomes, quality and cost, and also disparities, social determinants of health. The best way to get started is to find a mentor. I remember as an R1, I was looking at mentors and connecting with people, and I asked some of my seniors who would be good mentors to reach out to. And I remember one R4 said, you know, instead of reaching out to faculty, why don't you connect with this R4, Dr. Gelareh Sadigh? She's really great, and she has published a lot as a resident. And I did. Since then, we've had 2 grants together, lots of publications, and I'm happy to be her mentee. And just take the opportunity to turn problems into research ideas. And thank you very much.
Wonderful. Thank you, Patty. That was fabulous. Fabulous overview. Now we'll turn it over to Gelareh.
Thank you very much, Jerry. And thanks, Patty. It was my honor working with you as well. So let me just share my screen. Okay, so I'm going to give an overview of the health services research opportunities, like the part 2 section that Patty was going over it. These are just some disclosures. So she already went over this imaging value chain and different aspects of it. But the part that I want to focus on is this decision-making that happens between the patients and providers. And there are two components here. One is the provider making the initial decision of what to order and basically what are the options that are available. And the second piece is discussing that options with the patients and together coming into a shared decision-making. So I'm going to split this into two sections as we talk about the first part, provider decision-making. So for a provider to, based on everything that is going on with the patient, to come up with a decision that what to order, they need to gather data. And majority of these data obviously coming from the literature. And if you look at the literature, there are different types of studies that are going on, which have different levels of evidence. Like the provider want to see that what type of imaging I need to order for this patient. So they need to look for papers that are published on diagnostic accuracy of an imaging test. What is the diagnostic impact of that test? How does it impact patients' outcomes? And then as you go higher up the hierarchy of evidence, then they can look at comparative effectiveness. Maybe there is a new technology. How does this new technology compares to the standard of care that we already have? And then lastly, also looking at what is the cost effectiveness of this imaging that I would like to order. In the next few slides, same as Patty, I'm going to go over some papers that kind of highlights like all these decision-making that happens. So before we go through that, so from a provider perspective, there are a couple of questions always come to the mind. The first one is that even if does this patient requires imaging or not? And unfortunately, this question is usually overlooked, and we see that with the overutilization of the imaging in the last couple of years. We know every patient go to ED, comes back with a pan scan, which is not necessarily right. We know diagnostic yield of a lot of imaging is actually very low because they're just being ordered inappropriately. But in reality, the provider first should make that decision. Do I want to order an imaging for this problem or not? And then the second is once they determine that they need an imaging, they need to decide whether one imaging test is better than the other test. If I'm doing a procedure, one procedure is better than the other. And how does these two imaging tests that are my problem now impacts the treatments and patients' outcome? Is one of them more appropriate? Is one of them more effective? Is one of them more cost effective for the patient's conditions that we are talking about? And Patty went over the fact that, yes, we have decision support tools. Yes, we have ACR appropriateness criteria. But from a health services researcher, what feeds into these decision support tool or these ACR appropriateness criteria is those comparative and cost effectiveness studies that are published out there. Those are the ones that are providing the evidence for these decision support tools. So giving you an example of this, I was actually a resident at Emory, and we were noticing that patients who are having subarachnoid hemorrhage, not every patient going to have an aneurysm, obviously, like around 15% of these patients receive a DSA, and on DSA, they can't find any source for their hemorrhage. And then we were noticing that a lot of these patients, as a next step, an MRI brain and an MRI cervical spine is being ordered for them. And the reason behind that is that the neurosurgeon or neuro ICU team want to make sure that there is no underlying mass, like ependymoma or cavernoma that is cause of this hemorrhage. And obviously, you can't find that with a DSA. But what we noticed that a lot of these, especially the cervical spine MRIs, are coming back negative. And again, this comes back, you see this like low diagnostic yield in many other scenarios. Again, CTAs for dizziness and like whatever, altered mental status is like one of the main ones. But I'm bringing this as one example. And so we decided to do a multi-center study and look at what is the utilization rate and diagnostic yield of MRI cervical spine in this specific situation. And obviously, like we noticed that the diagnostic yield is super low, 0.2%. And we shared the information with our teams, our neurosurgeons, and we were able to change their management. Like they decided only if patient symptoms is directing them to a spine pathology, they ordered MRI cervical spine. So basically, this is like kind of like a literature. This was more of one of those diagnostic accuracy, like lower on the hierarchy of evidence, to provide evidence to affect providers' decision making. As a follow-up to this study, we actually did also a meta-analysis, which is a higher level of evidence to basically combine the results from all the other studies that are going on the same topic. And not surprisingly, we found that pulling like around 538 patients from 7 studies who have angionegative subarachnoid hemorrhage results in like a diagnostic yield of 1.3% for cervical MRI. Again, like another evidence for the provider helping them making a correct decision. The second piece that we talk about is if the provider knows that they need to order an imaging. An example is you're thinking about a kid that they're worried about kidney stone. And now, like making that decision making, I know I need an imaging, but what is that type of imaging I want to order? Do I need to order an ultrasound? Do I need to order a CT scan? And again, you can use like one of these decision support tools, or you can go into the literature, and this is part of that health services research that fills the literature to run an analysis on the effectiveness of the two modalities. And for example, based on this paper, we know ultrasound has higher specificity, but moderate sensitivity and higher false negative rates. So then from a provider perspective, you need to see what is your pretest probability, how worried are you, and then based on also obviously the safety of the modality, make a decision. Another example of which imaging is effective is this meta-analysis that we ran for intussusception reduction in children. You can use either air enema or liquid enema. And there was also a lot of discussion, which is the most effective one, which is having like better outcomes for the patients. And again, like you can pull the data from the papers that are out there. And what we found was actually air enema was superior to liquid, and also the success rate was higher, and there was no significant difference in the perforation rate, which is a common side effect from the air enema. So once you make that decision that you want to order a test and you know what tests you want to order, it comes to what is the protocoling for that test. A lot of times this falls under radiologists because we do, for example, protocoling for a lot of our MRs, but not necessarily like a lot for the CT scans, but also some of it falls on the provider when they order an exam. Should they order it with contrast or should they order it without contrast? And again, like determination of what is the best protocol that is useful falls under the health services research. Example of that, this study that was done at Emory, that they looked at for patients who are coming to the ED and they're getting an abdominal pelvic CT scan. If we don't give them an oral contrast versus we give them an oral contrast, what is the difference in the efficacy of it? What is the difference of it in the turnaround time, in the ED length of stay, and on patient safety? And actually, based on this same study, they changed. It was around 2015, I guess. This study, 2014, this study was published. They changed their way of ordering these things coming from the ED. So after a provider basically makes that initial decision, that it comes to the shared decision making that we are talking about. It's one thing that the provider tells the patients about all this information, which we call informed decision making. But the second part is that once a patient got informed, they bring in what their value and what their ideas are, and basically kind of that makes like basically a double way loop. And I mean, they participate in a shared decision making. So as a health services researcher, how you can impact patients' shared decision making? Usually from a patient perspective, once an effective imaging is being ordered, there are certain things that goes in their mind that can affect their decision making. One of them is what is their perceived risk of the condition that they are being offered to do a test. And an example of that is lung cancer screening. We know that, we have a large group of population that are eligible for lung cancer screening. However, the utilization rate or uptake rate of lung cancer screening among those who are eligible is only 4%, and which is a pretty low number for a screening test that is actually being covered by the insurance. And this number is even lower in minority populations, especially African American, Hispanics, and also Asians. And looking at a lot of studies that are looking at what are the barriers are, like whether these studies are from a survey perspective or doing qualitative interview, they see that, like, I mean, one of these barriers is the perceived risk. I mean, if a patient do not think that, or they don't have like this thought that they can get the cancer, then their utilization rate of those specific preventive service gonna be low. So again, like, studies that are looking at the barriers of a recommended or appropriate care, I mean, such as like looking at perceived risk, falls into the health services research realm. The second part is, okay, so again, like, we know something needs to be ordered for the patient, but what is patient preference regarding that? Because again, as we talk, a lot of things that we order for the patient not necessarily happens. And one of these falls under patient preferences. And an example of that is for colorectal cancer screening. We know we have different modalities for colorectal cancer screening. I mean, colonoscopy, CT colonography is one of them. We know they have different sensitivity, specificity. One is better for polyps that are less than 1. But once like a provider comes with a decision that, like, I want to basically order a test for this patient for colorectal cancer screening, that's where that patient preference come into play. And there have been studies that are part of that, again, like health services research, as we're talking about, looking at what is public perception or preferences, for example, for CT colonography or colonoscopy for colorectal cancer screening. Obviously, a lot of patients actually prefer the CT colonography because it doesn't have as bad of a bowel prep that the colonoscopy has. And if ordering one test really results in patient doing that test, so that's the part component of shared decision making that maybe that the patient provider needs to go for, and that's again the focus of a health services research, how you can improve that shared decision making. Another example is even like, I mean, looking at what our patients' preferences are for different types of bowel prep prior to the screening CT colonography. Again, like, if we have this sort of data as a provider, you can make a better decision of what needs to be ordered for the patient, and you can improve patients' adherence to that recommended care. One other piece that is an area of interest for me is the medical financial hardship. Again, this is an area that results in a patient do not adhere to the recommended care. There are a lot of studies, many studies going on looking at the prevalence of medical financial hardship. We did this study with collaboration with University of Michigan. We actually looked at patients who are coming to radiology waiting room as an outpatient and assess what is the degree of financial hardship in these patients. And when we talk about financial hardship, just look to give you an overview, it's basically composed of different domains, like patients having an anxiety because they can't afford care, patients actually forego medical care because of the cost, and also medical debt is one of them. And among these patients, around 15% of our patients endorse at least one episode of care non-adherence in the last 3 months because of the cost. So we are specifically looking at their basically care non-adherence or behavioral changes that is coming from medical financial hardship. And around 5% of them mentioned that they decline diagnostic tests just because of that reason. So again, talking about the cost with the patient is a way of improving shared decision-making. And again, how to improve that shared decision-making is a focus of health services research. Another example of how this medical financial hardship can affect patients' care is this study by Tran et al. From UPenn, which showed that among patients who are getting screening mammography, usually screening mammography, as you know, is covered by the majority of the insurance. There is some older insurance that may still not cover it. And they showed that they used the claim-based database analysis, and they showed that for every $100 increase in patient out-of-pocket cost just for a screening mammography, the chance that that patient comes back in the next 12 to 24 months and get another mammography decreases 1.9%. %. And also the same study showed that, so as you know, I mean, a lot of times we do a screening mammography, but patients can have a callback. We have 10% callback, which patient's gonna come, needs probably a biopsy or a diagnostic mammography, an ultrasound, like a modality or a procedure that is not being covered by the insurance. And that same study showed that any out-of-pocket cost that is coming for the follow-up test after that baseline mammography results in 2.7% lower probability of patients coming back. So again, like another idea that like how you want to talk about the cost. Maybe when you are offering a test, you want to first like ensure patient knows that test gonna be for free based on their insurance, like a preventive test. I mean, if it's not a preventive test, maybe you want to discuss about the cost. And if patient needs some sort of assistance, you refer them for financial assistance programs. But also a lot of time, like just making patients mentally prepared gonna help them to have a better adherence to the care that they need to. This is an example of, we are currently running a study actually that are looking at the patient's health-related social risks and also medical financial hardship in imaging center. And so I send these surveys through emails to the group of patients that are eligible. And from time to time, I usually get like on a daily basis, emails from them back. Some of them upset why I sent such a survey because they are wealthy, and some of them who are actually affected by the cost share their experience. And this is the experience that one of them shared with me, that they need an ultrasound and a diagnostic mammography. They are, if they file that claim with their insurance at the imaging facility A, it's going to cost them around $1,500. If they don't use their insurance and they pay as a cash patient in the same imaging facility, it's going to be actually cheaper, $1,200. But if they get that imaging from another imaging facility, it's actually going to be much, much cheaper, and it's going to be around $400. And basically asking me why I should even like get my imaging in the facility A. I'm very interested in facility A because my provider is there. But again, like this comes into that shared decision making, that what goes into your patient's mind, what type of discussion you need to have with the patient, and how health services research can improve this shared decision making. And as you see, one of the problems with what I mentioned is that a lot of patients right now, when there is a cost discussion, even if a cost discussion happening as part of the shared decision-making, there's no quality discussion. So there's always like the quality information of these different imaging centers are missing. I don't say cheap necessarily means low quality, because that's not true. But I mean, if you don't have the quality metrics, then your information is not complete. And studies have shown that increasing access to price may not improve informed decision-making unless it's accompanied by information about quality. Because when you don't have the quality information and your patient is price sensitive, same as the patient that I shared their experience with you, they're always going to look for cheaper services. And if you don't have the quality information, the patient who has less price sensitivity, like patients who have already used their deductible for the year, they may choose the more expensive option with the idea that a more expensive means better quality. And also studies have shown that patients actually can identify high value care when they are presented with both quality and data. An example of that is this study that we did looking at cost versus quality in imaging examination decision. This was a study that we did a conjoint analysis for patients who are having with hypothetical back pain, both hypothetical mild back pain and severe back pain. And we were giving them scenarios. We were giving them different costs for their MRI of lumbar spine that they may need and different quality metrics for the imaging centers that they can choose from. And these quality metrics included what is the accuracy of that imaging center, which is not a correct quality metric because there's no way actually to find what is the accuracy, but we figured it's something that patient might be interested in. Whether that imaging center is recommended by the doctor or not, whether there is, what is the online rating of that imaging center. And what we found that for situations such as a mild back pain, patients don't care about the quality. They are actually like, there's no significant difference. Like they can go either way. They can go either like cheap or like high quality. So there's no significant difference between quality and cost that patient cares about. But once problem becomes severe, such as severe back pain, patient always choose quality over cost. Again, it's another opportunity that how with health services research, you can bring the quality into that shared decision making. Lastly, I want to talk about the impact of policy change. Again, these are part of the health services research. We know different policies have been going on in different timelines, and like how that impacted the utilization of the imaging services is very important. Is it from the Affordable Care Act that results in a lot of patients getting access to preventive services and its impact on utilization of these preventive services? Is it from the USPSTF guideline changes from the lung cancer screening to screening mammography, and like how this impacts patients using these services? Is it hospital price transparency and how that informed the patient's decision-making? Is it No Surprise Act of 2022, or is it 21st Century Cure Act with patients having access to patient portals and so on? And lastly, also, I want to focus on, again, as part of this health services research, while we went over the imaging value chain and what are the opportunities are, there's also opportunities for some sort of a multi-level intervention once you identify what is the barrier is. And whether this multi-level intervention is including, like, I mean, this is like basically an onion model of what are these levels that you can intervene on, whether it's like at individual level and you can improve patients' awareness or knowledge by giving education, by improving their perceived risk, or is it interpersonal? You can improve the patient and provider relationship. You can decrease the language barrier or cultural barrier that might be a problem for, again, patients making that basically informed and shared decision making. Whether it's organizational, basically looking at difficulties accessing care, cultural differences between patients and providers, whether it's societal or cultural norms, like their lack of cultural emphasis on prevention. And then finally, at the policy or structural level, how you can improve insurance coverage, how you can change the policy for the insurance, not only cover your preventive service, but also the downstream services that is after that preventive service. If lung cancer screening is free, you want that follow-up lung cancer screening for the nodules be free. If screening mammography is free, you want that follow-up diagnostic mammography to be free as well. And then with that, I want to end up that like any aspect of this imaging value change is an opportunity for a health services researcher to focus on. Thank you very much again.
Wonderful. Thank you so much, Gelareh and Patty, for really comprehensive overview of what one might encounter in health services research. I just want to remind the audience, if you do have questions, please put them in the chat and we can unmute you so you can participate live. Patty, I'd just like to ask you, and Gelareh, you can chime in as well. You know, from sort of the 40,000 foot level, why you decided to focus on health services research in the first place, and what are some of the challenges maybe you faced that were unexpected in going in that direction, and advice that you could pass on to other young researchers?
Yeah, absolutely. So my pathway was a little bit unusual. I started with a research fellowship in imaging informatics, and that's how I started my research career even before residency. And with imaging informatics at the time, I had to learn a lot about health policy because of PAMA and all the policy implications of the HITECH Act and things like that, just to, in the process of evaluating the IT tools and the interventions, I just had to learn the background of it. And I got interested in health policy, and a lot of the examples that I gave were IT interventions, because that's my area of interest. And that's how I got involved. As far as challenges, I think that in radiology, there are not a lot of people doing health services research. So in the very beginning, I had some challenges just getting connected and finding, and I did not even know what health services research was until I met with a mentor and I described my interest and they said, oh, you're interested in health services research. I'm like, oh, okay, I guess I am. So I think there is a lack of awareness for trainees coming into the field. And that was a challenge for me, just to figure out what this is and what my interest is.
And advice to young researchers?
Yeah, as far as advice, in addition to finding a mentor that I described, I'd say just go out of your comfort zone. And if you have to reach out to people that you never talked to, just do it. You'll be surprised how open everyone is, and even, full professors like Dr. Jarvik will be very open to talking to someone. And when I first started, I just emailed a lot of people at Emory and sent maybe 10 emails and set up one-on-one meetings. So definitely talk to people and get that networking.
Yeah, I mean, one of the things is if you're at a great institution like Emory, there are lots of resources that you can find at your home institution. Not everyone is so lucky, but I would say, and I don't know if you reached out to people beyond Emory, because we are definitely open to collaborating, mentoring, helping people, even if they're not at your own institution.
Yeah, absolutely. I think that I've been very lucky to have found this community at AUR as well, and have some official and unofficial mentors, including Dr. Carlos, who here and there will meet with me and give me some tips. It is very important to have mentors outside of your institution as well, I think.
Yeah, and as you point out, AUR and RASHR in particular are great resources for that. Gelareh, do you have anything you'd like to add?
Sure, and I think we have also one question from
Yeah.
Paul Chatbox. So for me, there are some basically similar themes you're going to hear from me and Patty. One is obviously a lot of these research problems are a problem that you encounter on a day-to-day basis that you get into it. So you need to have that motivation to do the health services because you encountered the problem. A lot of my own involvement with the financial hardship, it was a surprise bill I got after my pregnancy. And so that's make you get into, but more important than that is the mentorship that she talked about. I feel like, for me, my first mentor was Dr. Ruth Carlos. I was also a research fellow before starting my residency. And I think I learned a lot. And then she pushed me to contact a lot of different people out of my comfort zone, whether it's institutional or outside institution, to get to know people, to talk about my idea, to get feedback, to be open to that criticism so that you can shape your idea. I don't remember that. I remember that when after I got my giraffe and I was thinking about what should be my next grant idea be. And she told me, I want you every month, email a person from outside Emory and tell them that is working on the same area that you're working, tell them about your idea and get their feedback. And I think that was the thing that made me move through, basically, and get ideas, shape my ideas based on those feedbacks that I'm getting. So I think mentorship is important. RASHR is a great community of people. You were my giraffe mentor. So, being connected to you, that was a great, opportunity. I learned a lot from you, Jerry. And so, all the people in RASHR, it's a great, connection for the people to get together.
If we only could all just have Ruth Carlos as our mentor, it would be easy. Say, Kara, can you unmute Paul Bunch? And Paul, you could just ask your question.
Yeah, so I was really interested in some of the papers that I think both of you have been involved with, using sort of publicly available data sets to try to answer some really interesting questions. And I I understand I should seek out mentors with experience in that, but just kind of going into that process, are some of these easier to navigate than others from a like beginner perspective, or is that even something I should consider? Do I need to go find someone like Dr. Dusak or the like to help with this?
How do you want to go first?
Yeah, sure. So there are some open databases and free databases like the Medicare. And they can be hard to navigate if you, for when the first time that you get them, even if you're familiar with big data, you just take the time to go through the data dictionary and understand the data, and even to open the data, it's not going to open on a regular Excel. You would need statistical software. So for junior faculty who wants to go in that direction, I highly recommend partnership with someone who's either in the School of Public Health or a PhD who has data analysis experience. And that is one advice actually that Dr. Carlos gave me early on, was just as faculty, you have to partner with people outside of the School of Medicine, outside of your department, and reach out to School of Public Health. So I did that, and that was very helpful. I think that some, maybe the paid databases, they might be a little bit more organized than the Medicare. So if you have someone who has worked with those databases before, who can work with you on the project, that can be extremely helpful.
I can add to that as well. So as you both mentioned, there are some public databases that are for free. Those are usually easier to work with. Like examples of them are HINTS, MEPS database, NHIS, which is National Health Interview Survey. So they are usually, if you work on 1 or 2 years of them, they have a smaller data dictionary. It's like not that many variable as some of the larger databases that you need to pay for. Obviously, the type of research that you can do with these databases, because they're publicly available and free, is much more limited. You need to look into their survey questionnaire, which is online available, to find exactly what question you have and come up with the hypothesis that what you want to assess before even like going into the analysis. But again, it's going to be much more limited what you can do with these sort of databases. Despite that, you still probably need either a statistician, or if you know yourself statistic, I think it's doable. If you know the basics of the statistics, just play with the database, and you just need to have access, obviously, to statistical software to be able to run the analysis. But they are much more manageable, like than some larger databases. So when you get to the larger databases, like the cheaper one gonna be the HCOP database, which is the NEDS, and NIS, the National Inpatient Database, National Emergency Database. So you need to pay for them, and they have much more variable, and you're going to answer some other different types of questions with them, but then it becomes more expensive. Like some of the Medicare identifiable files, those are more expensive, and then you get to Optum and Market Scan, which you need to pay $50K per year just for maintenance, and much more expensive. So depending on what are your resources are and what your research question is, I think you can choose what database you can work with. If you don't have that much infrastructure, start with the easy ones. I usually, like when I work with the students, like I start off these like publicly available. It's a good way for them to formulate a question and basically run a small analysis. But I mean, obviously, if you're looking at like some other more detailed questions, you may want to look at some of those like databases that you need to pay. And then again, like some of those databases are longitudinal. You can follow a patient over the episode of care, such as Optum, Market Scan, Medicare. Some of them are like HCOP are limited. It's only on ED encounter. You don't know what happened before. You don't know whether patient got admitted or not. Or some of them are only focusing on inpatient. You don't know where does this patient comes from after they got discharged, what happens to them. So again, you need to find out what the question is and then go from there.
Thank you both so much. That was super helpful. I really appreciate it.
And, just to quickly clarify, something about the CMS data is that you may be able to access it without paying if you partner with someone that already has access to the CMS data, like the ACR, for example, the Neiman Center. has CMS data, or there may be investigators at your institution. But in general, it's not free, actually, the CMS data, and you have to go through this intermediary ResDAC, and it can be quite complicated. And one of the things I just want to emphasize that Gelareh said, both actually Patty and Gelareh, is partnering with people who are already working with the data is a great way of getting started, because understanding what the limitations of the data set are is equally as, if not more important than understanding what you can do with the data sets. And it's sort of easy to go wrong there. So just wanted to add that. Anyone else have any questions? If not, I just want to thank both Patty and Gelareh again for doing a fabulous job being the lead-off batters for this new series. I want to remind everyone that our next scheduled webinar is March 8th, and Answer will be taking the podium then. So until then, thanks so much for joining us. Thanks, everyone, and have a great rest of your day.
Thank you.
Thank you.